And that can be a very difficult sell for some people who, understandably, they've actually been in a lot of pain, just come for a long period of time, wants a more instantaneous result.
Yeah, I think when you talk about surgery for low back pain, that's the thing that's given spinal surgery the bad name that the general public have about it, because it's so unreliable, and so difficult to determine for low back pain which operation may or may not help, because it's a very vague area as to where the pain generator is coming from.
And why do you think that's the case?
I think the structure of the lumbar spine is so complex and so richly innervated with nerves that there are multiple tissues which could be pain generators. There are the facet joints, the articular surfaces, the joint capsules, the ligaments, and the annulus fibres, and you often get patients with multi-level degenerative change, and every disc and every joint in the lumbar spine is bad, degenerate, arthritic. What do you do? Where do you operate there? Where is the pain generator? So it can be very difficult to isolate the diagnosis to try and do an operation which may help them. Low back pain surgery is not a very big part of my practice. In other words, fusion surgeries, those sorts of things. You have to sort of be able to isolate one area, which is quite clearly the pain generator, before talking about fusions and whatever. I mean, I use a lot of injection procedures, either under radiology or with myself, for like facet joint injections, nerve root blocks, those sorts of things, to A, try and help people, and B, try and isolate where the problem's coming from.
So it's very much like a diagnostic tool as much as a therapeutic.
Yes, it can be both diagnostic and therapeutic, yeah, for sure. The good parts of spinal surgery, or the more reliable ones, are of course where you've got nerve root compression. People with raging sciatica, intolerable leg pain, and a disc proven on MRI causing compression. Well, that going in there and just removing the pressure on the nerve has a 97% chance of giving them instantaneous relief. And they're the most happy people I've had to operate on, those sorts of people. But the patients with multi-level degenerative change and back pain, I usually say, well, sorry, you've got to go back to the physio, chiro, osteo and learn to adapt your life to deal with this. There is no magic wand for your condition.
Talking about pain-generating tissue, one tissue that you didn't mention that I think is of interest is the muscular and fascial system.
Yeah, sure.
And the issue that we have with that is, unless there is like a clear loss of structural integrity, if they have a strain, which doesn't seem to be very common, say in the muscular tissue around the lumbar. But are you aware of any research, or do you look for potential changes within the soft tissue structures that may generate pain? And if so, how do you go about trying to quantify or determine that?
The fascial structures, that's quite a grey area, and the musculoskeletal medicine practitioners lean more towards injections into fascia, etc., or doing certain procedures where they incise fascia percutaneously. A lot of the muscular pain, I feel, is like a guarding spasm for an underlying problem.
Yes.
So you have an underlying problem, the body automatically goes into protection mode, calls upon the erector spinae group and other muscles to lock on to protect and stop movement, and you get a lot of pain from the muscle spasm associated with it. So I think you're right, that's another potential pain generator, which is sort of indirectly related to the underlying problem.
Yeah, it's an area that I'm particularly interested in.